Mhm. Good afternoon, everybody. Welcome to Deep Dive for today, 13th of May, from a rather grey Pietermaritzburg. Okay, so our topic for today is joint health in haemophilia, specifically in haemophilia A, in an evolving treatment landscapes. And we've seen a lot of advancement recently in terms of gene therapy as well as the use of ultrasound. So with MASAC, there was an ultrasound workshop that was done, I think it was last year, and we are looking eagerly at how to incorporate ultrasound, for example, in care of patients with hemophilia. So we are joined this afternoon by Professor Annette van Drogalski. It's a very bright and early start for her. It's 7 o'clock in the US. So she is Professor of Clinical Medicine in the Division of Hematology Oncology, and she is the Director of the Hemophilia and Thrombosis Treatment Center in the Department of Medicine at the University of California in San Diego. She has got 2 degrees to start off with, both a pharmaceutical and a medical degree, and that is from Ludwig Maximilians University in Munich, Germany. And then she moved to complete her residency in internal medicine at the University of Wisconsin. This was followed by a fellowship in hematology and oncology at the University of California, San Diego, and the Scripps Research Institute. So in chatting to her briefly before the session started, she is involved mainly in the care of adult patients, and this is patients with hemophilia and other bleeding disorders, specifically addressing the evolving need of aging patients. So for those who know me, as I'm actually a pediatric hematologist, and I look actually at what the landscape brings for the future. So survival's definitely improved, and I hope that we are transitioning patients, pediatric patients, to the adult services with much better joints than we did many years ago before we had improved access to factor as well as the newer therapies. Prof. van Drogalski also has interests in new therapies, cardiovascular disease and hypertension, and then in the progression of hemophiliac joint disease. So she is involved in gene therapy trials as well as novel molecules in with regards to hemophilia. She has also pioneered musculoskeletal ultrasound for rapid joint bleed detection and joint evaluation in hemophilia, and she is certified in musculoskeletal ultrasound by the American Registry of Diagnostic Medical Sonography. To this end, she has developed the Joint Activity and Damage Exam, which is a validated ultrasound protocol to quantify synovial and osteochondral changes, as well as inflammation in the hemophiliac joint. She is also credited, and I look at this with interest because I'm looking at what further collaboration we can have as the South African Haemophilia Foundation and MASAC. She is director of the CME accredited course, Musculoskeletal Ultrasound in Hemophilia, at the University of California. Interestingly, she's also developed a focus in international outreach to afford training for hematologists in developing countries, and she has done work in Mozambique as our neighbor. So for those of you who have joined us previously with the deep dive, just to go through a few of the housekeeping rules. So we are blessed in that the recordings of all of these meetings are actually accessible to all. And this is at the website bloodsa.org.za under resources. If you have any questions or comments to be raised, then please add these to the chat box and we will bring these to the discussion. If you have any requests in terms of the mailing list, your go-to person is Melanie. And then critically, yes, you do qualify for CPD points, but you need to stay for at least an hour and we need your MP number. In order to always improve meetings, feedback is critical and feedback that is honest. Rest assured that this is anonymous. Just two conferences that we want to bring your attention to. So the first is the 14th International Donor Registry Conference and WMDA meeting. And that's happening in June, 25th to the 29th of next month in Cape Town. The theme for this meeting is All Patients and Donors Matter, and it promises to be a good meeting. So just also to note that the South African Bone Marrow Registry has got a discounted conference registration rate of 5,900 for any of the members of the organizations listed above. We also want to bring your attention to the 16th Annual Heme-Onc Symposium, again in Cape Town. That date is from the 13th to the 15th of September, and that would be held at Century City. A reminder of who your management team is in terms of the deep dive initiative. So Estelle Verberg needs no introduction. I don't think Gerdien needs any introduction either. Your CPD administrator is Melanie, and then we've got Bridget who has joined more recently. So our agenda today is considerations for joint health in an era of treatment advances. And Prof. Annette, we welcome you and we look forward to your talk with us this afternoon. So Prof would be speaking for roughly an hour, and then we will have 20 to 25 minutes for Q&A with the intention of finishing the meeting at 5:30.
Okay, then I think I take over. Thank you much, Dr. Goga, for this lovely invitation. And I have to say, it's early morning here, 7 a.m., so it's tea time. So on occasions, you see me lift my cup, but I guess it's tea time in South Africa too, 4 p.m. So we share something here. So let me manage to share my slides. Share. And then can you see them? I'm going into slide mode. Can you see them?
We are seeing your desktop at the moment.
You do not see. Okay, so let me unshare again. I probably have the wrong.
Yep. Yes, we are seeing your slides.
No, I have to think. Maybe I shared the wrong desktop. 1 second. Okay, let's try again. How about now? Do you see the slide?
Prof, I'm not sure if you want to do it in presenter mode.
Of course, yes. But you see them all now, the slides?
Perfectly, thank you.
Okay, perfect. Okay, then let's get started. Today, it's my assignment and pleasure to orient you to more of joint health in hemophilia in this evolving treatment landscape. So as an outline, I thought we go over some general considerations regarding hemophilia, current options for prophylaxis, then of course hemophilic arthropathy with point-of-care imaging, assessment and management of acute pains, the longitudinal follow-up of joint health, and then management of progressive arthropathy. These are the abbreviations I use, something like annual joint bleed rate, point of care, POCUS is point of care ultrasound, and MUSCUS for musculoskeletal ultrasound. General clinical implications of joint bleeding. Joint bleeding is the most frequent bleeding manifestations of severe hemophilia, leading to arthropathy. And arthropathy is characterized by joint deformities, by acute and chronic pain. And then, of course, in my world, the adult world, reduce quality of life and also productivity. Most bleeding episodes in hemophilia do occur into joints. About 80% of bleeding episodes are joint bleeds. And the bleeding location tends to vary somewhat with aging. I think we all know that elbows, knees, and ankles are the most affected joints, particularly in childhood, also in adulthood, but some other joints have to be considered then, like shoulder and hip. And particularly take note of the ankle here that worsens. Most adult patients at some point have real bad ankle problems, or if they have breakthrough bleeds, often continues at worst is in the ankle. Prevention of joint and other bleeding complications. What will it take? You see here this little boy in Bangladesh. He has severe hemophilia and he is on crutches. And you see this little boy here in France riding his bike without problems. He also has severe hemophilia. And what stands in between them and their outcomes is simply prophylaxis. Prevent the bleeding. So that can be achieved with factor 8 or factor 9 clotting factor products, with emicizumab or Hemlibra, which is approved for prophylaxis, and new rebalancing agents in the pipeline, several to come, non-factor treatments. We will briefly talk about them. And then also gene therapy, recently approved in the US and in Europe. Now, the principles of those prophylactic treatments, very simple. So as we said, we have clotting factor, and here we have conventional half-life and extended half-life products. And that really requires intravenous access several times a week, not always as easy for patients and families. Now we come into the era of rebalancing agents, here with the poster child and approved Hemlibra. And we go to subcutaneous injections, and they can be weekly up to monthly only, depends on how much dose a patient is able to tolerate in one subcutaneous injection. And then, of course, we have now gene therapy, and here you see the approved products. And that's supposed to be intravenous, 1 or 2 hours, once in a lifetime. And matter of factly, on Wednesday, we will have our first commercial gene therapy done at our center. Hemgenix has become the world's most expensive drug with $3.5 million for this once in a lifetime infusion. So what are the progressions of concepts for prophylaxis? Well, when I started like 15 years ago, all there was clotting factor, short half-life, and patients go through these peaks, as you can see here, and troughs. The half-life is about 8 to 10 hours of a conventional product. So after infusion, they'll be almost normalized, and then within 2 days, they are down to baseline, and it has this kind of zigzag form. And with that, of course, the factor levels go up and down. And this here at a low trough level, let's say, they are most vulnerable for breakthrough bleeds. Then we went into the era of extended half-life factor products. And you can see that the peak and trough issue is somewhat mitigated by the troughs here being protracted and at a higher level. And that, of course, can also be measured by factor levels. Now, if we think about non-factor therapy, then in terms of hemostasis, you see this sort of mild and moderate continuous hemostasis effect without peaks and troughs, but that cannot be measured by any factor levels because it's non-factor therapy. And then we have the hope, at least of gene therapy, to provide ideal prophylaxis at a really high level of hemostasis with measurable factor levels. Again, that's the hope. I think we all know that in the end, gene therapy didn't quite pan out that way, but these are just the concepts. Now, what about rebalancing agents? They were inspired by the absolute need to develop better treatments for patients with inhibitors where bypassing agents, etc., are not particularly effective. And so what you can see here is substitution therapies such as emicizumab or Hemlibra, providing a factor 8 substitute. We come in a moment to that. Or rebalancing therapies, in essence, one removes natural anticoagulants and then makes the body more prone to clotting. For instance, if one issues a monoclonal antibody or an inhibitor to tissue factor pathway inhibitor, then that pathway will be inhibited and there is simply more 10A formation and thrombin formation. Or if one takes out antithrombin, the drug is called fitusiran and is currently in clinical trials, then natural inhibitor is removed, so maybe then there is more thrombin formation, and the similar concept for protein C and protein S. Now, all of these are still in clinical development and stage for many. Really on the market only is emicizumab or Hemlibra. And this is a cartoon of Hemlibra. It's a novel humanized bispecific monoclonal antibody. It bridges factor 9A and 10 to restore function of missing factor 8, because that is exactly what factor 8 does in real life. It's a cofactor to bring these two factors together on the platelet surface and then initiate clotting. There is no structural homology to factor 8, so it's not expected to induce any factor 8 inhibitors or be affected by the presence of inhibitors. So it's factor 8 therapy without factor 8. And it's indicated for hemophilia A with and without inhibitors. And again, it's a subcutaneous injection. What do the pooled analyses of long-term results from phase 3 studies show? So this is sort of a long-term experiment where all the phase Haven 1 to 4 data, these are the phase 3 trials for Hemlibra, are summarized. And shown here is about a 3-year follow-up, where you can see here on the y-axis, we have the calculate median ABR. So you can see that after 3 years, the mean ABR has sort of stabilized out at somewhat of 0.7, let's call it 1, with quite some spread, I will say. Some have 5, some have 0. And I bring this up because this is perceived patient bleeding. Patient tells us historically if they think they have a joint bleed or not. And they might be mistaken on occasions. It's not very accurate. And this is, we come to it later, musculoskeletal ultrasound to provide more precision. So just keep that in mind. But overall, Hemlibra is really effective. You can see here that over 80% of patients, all comers on Hemlibra, are in the 0 treated joint bleed zone. That's really good. And about 15% or so have still 1 to 3 joint bleeds a year. And it was well tolerated. And here this cartoon comes back to that steady state issue with hemostasis. So after 4 induction doses, the drug level of Hemlibra remains steady state at a sort of low level of hemostasis. Not quite clear because we can't measure factor 8, but anything, let's say, between 10 and 30%, quote unquote, factor equivalency. So transforms the patient into a mild, moderate to mild phenotype. The availability of products for prophylaxis, though, is dependent on country and jurisdiction. While all are efficacious to some extent to reduce bleeding, bleeding cannot be entirely avoided. And I think this is today's gist of the talk. So what is joint bleed frequency in the era of factor prophylaxis? We have already a few slides back seen what Hemlibra can do, but especially with factor prophylaxis and probably with short half-life prophylaxis, despite prophylactic treatment, these acute breakthrough bleeds and also subclinical bleeding, meaning no symptoms, there's just blood in the joint, can still occur. And that does result in joint damage and arthropathy. And maybe the best evidence for that right now is a meta-analysis of 48 studies checking bleeding events in severe hemophilia A without inhibitors on all-comer factor 8 prophylaxis. And in that meta-analysis, 48 interventional studies and 10 observational studies were pooled to show very similar results, that the mean annualized joint bleed rate is about 2.6 to 2.6. And that 38% of participants here and 21.8 or so participants there have 0 bleeding. So that leaves about 70% of patients with joint bleeding. If it's just one joint bleed or 5 joint bleed, that's not quite clear, but doesn't matter. The majority does have joint bleeding, and that in return causes joint disease. So I want to point out that there might not just be these obvious joint bleeds with pain and swelling and sort of the classical symptoms we assume, but there are also subclinical joint bleeds. And arthropathic joints may have bloody infusion without acute symptoms, and that's been shown in several studies. So the evidence for subclinical joint bleeding is actually present in about 30% of adults, and here mostly arthropathic joints. That's kind of logic because these joints are predisposed, they are destroyed to probably having blood in them. So absent elimination of joint bleeding, progression of musculoskeletal complications, particularly hemophilic arthropathy, needs optimization. And here we need diagnostic point of care tools for targeted, tailored, and appropriate management. And we come to that. Joint health varies globally though. And despite the significant reduction of bleeding due to standard of care prophylaxis, worse joint health is observed in regions where prophylaxis is not widely accessible. I think that picture that I showed before of the little boy in Bangladesh and the other boy in France illustrates that very well. And let's just take a look in terms of percent prophylaxis per gross national income. And I want to particularly focus you here to the right of that graph. Here divided by decades, let's say 2001 to 2010 and 2011 to 2020. And on the y-axis, you have the percent of patients on prophylaxis. Now you can see that the percent patients on prophylaxis in low middle income countries here in blue, let's say, is about 23%. Compare that to about 70% for upper and middle income countries in orange. And then in gray, you have the high income countries. And sort of this discrepancy is visible since almost here like a century or a quarter or 3/4 of a century going back to this portion of the graph. But it's gotten better. Clearly, we have now a fourth in low middle and low income countries on prophylaxis, but it's probably not enough. And then 70% in the upper and middle income country is good, but obviously not perfect. And well, I let that sink in a little bit because we do have healthcare disparities throughout the world. So hemophilic arthropathy appears unavoidable despite prophylactic treatments because of breakthrough bleeds, even with the best of all prophylaxis. And that creates a debilitating condition already present at young ages. Now, let's come a bit to the pathobiology. I think we can all agree on the fact that iron is the incendiary. That's widely accepted, that iron is propelling joint deterioration. It's released into the surrounding tissue by lysis of extravasated erythrocytes, and then it causes oxidative stress, cellular injury due to the formation of hydroxy radicals. That's particularly damaging for the cartilage, but it also causes this synovial hypertrophy, or at least associated with the development of synovial hypertrophy, neovascularization, vascular remodeling, which then with leaky vessels causes more bleeding, maybe also problematic for silent bleeding in the joint. And so this becomes sort of this vicious cycle of bad arthropathy. And let's keep that neovascularization and vascular remodeling in the backs of our head for a moment. So iron is stored as hemosiderin. I've visualized it here for you. It accumulates in various tissues. For instance, this is synovium intraoperative, and you see this iron-laden black mass, which is in essence synovium. It's been identified also in bone cysts and cartilage. So come back to synovium first. This is an MRI, and all this black lining here is blackout synovium. The radiologists call it blackout, zero signal. That is synovial hypertrophy as it shows on the MRI, black hemosiderin. And at the same token, you see this black hemosiderin here accumulating in arthropathic or osteochondral cysts in the MRI, and on an explant in that cystic content, you can see these enlarged remodeling vessels. This is alpha SMA staining, stands for smooth muscle actin. And you can also appreciate all these hemosiderin deposits, which is Prussian blue staining for iron, next to these vessels and throughout the cystic content. That is here showing the iron even in the cartilage, where you might not think it is, because we always think it's just in the synovium, but no, it's here a special MRI that shows it in the patella cartilage. And then again on explants, this is hemosiderin in chondrons. You can see they are hemosiderin filled. Now, why is that important? Because the extent of hemosiderin accumulation in cartilage and subchondral cysts relates directly to joint health. So iron is really a toxic payload, and you can see that here in a graph. On the left is the so-called hemophilia joint health score. The higher the score, the worse the joint. And this is graphed here against T2 star relaxation of the MRI. The less T2 star, the more iron. And you can see with more iron, there is worse hemophilia joint health score, and there is more of an MRI damage score present. Now, hemophilia joint health score is also worse in joints with high cystic iron content. So the more, the worse. With that new information in mind, I think it might be helpful to sort of propose an evolution of bleed sites. Traditionally, one always thinks about intracavitary bleed, that blood that's detectable right in the joint cavity. And that might be true in childhood. And if it's repeated in rapid succession within a few months, one has a target joint that then starts to get synovial hypertrophy. And again, that vascular remodeling with leaky vessels. So think about a new bleed site here, leaky vessels with blood in the synovium, and then hemosiderin accumulating in the synovium. And then finally, that leads to arthritis, and every arthritis gets osteoarthritic cysts. So bone cysts. And so these cysts, as we have seen, can also bleed. So now we start to have quote unquote bone bleeding. So all of that is not quite clear, neither the sequence nor how that contributes to pain or how we need to evaluate patients for this, but just have that concept in mind. What is not easily explained, though, is that clinical observation of hemosiderin accumulation or continued presence despite, let's say, at least symptomatic bleed control. So it doesn't resolve. Once there's a lot of hemosiderin in the joint, it's just hanging around and doing its thing. And no one knows exactly why, but there are some new studies to suggest that perhaps this is due to a defect in adaptive lymphangiogenesis. And that was shown in hemophilic joints, resulting in retention of iron-laden macrophages in the synovium. Macrophages do need to go out via the lymph system, and if they're iron-laden and are stuck in there to whatever defect, they don't get out. And that's shown here in a 4 weeks post-mouse bleed. You can see here the accumulation of these iron-laden macrophages with no way to exit the joint. And in parallel, I'm not showing those data, there is also absent adaptive lymphangiogenesis. Now we come back to this concept of vascular remodeling and bleeding, because this happens independent of coagulation. As we already mentioned, joint bleeding is associated with reactive synovial hypertrophy and vascular remodeling. That vascular remodeling is associated with vessel fragility and then more bleeding. And so one gets into that vicious cycle of vascular bleeding, in part independent of coagulation. And so let me show you here this pronounced expression again of alpha SMA, this mesenchymal marker of vascular remodeling in human factor VIII deficient patient compared to a factor VIII deficiency model in the mouse. And you see here these huge vessels stained very thickly and prominently, and that's also true in the mouse after joint bleeding. And that's not really present to that extent in osteoarthritis, be it human or mouse model, or rheumatoid arthritis. So think about the leaky vessel thicker is not always better. And so it's been shown that there is dye extravasation from these vessels. Think of it, I have this from a Google image, as really a thick vessel that has these leaky streaks. And that is illustrated in a patient of mine here who had undergone liver transplantation and therefore was cured of his hemophilia A with about 100% factor VIII levels. And about 8 years after this transplant, he comes with a really bad joint bleed because he had take some aspirin for heart disease. And you can see here this absolutely abnormal vascularization of the hypertrophied synovium that wasn't regressive. And even the dye extravasation in this area on angiogram. And then that would be his ultrasound, accompanying ultrasound with this big blotches of vascular remodeling. That's power Doppler signal showing these abnormal leaky vessels. So and that turns back a little bit, if I may, to say this could be at the edge of also silent bleeding, because these vessels, again, might be just silently leaking all the time in some patients. So for musculoskeletal health, so how to know when joint pain is related to bleeding. We talk about the obvious joint bleeds now, and then how to assess joint health longitudinally. So that brings us to best utilization of point-of-care musculoskeletal ultrasound. And yes, to Dr. Goga's point, we had a lovely ultrasound course about July, 8 or 9 months ago in Johannesburg. And I recognize that some of you who are on this presentation, on this call today, were present, and we had a real good time. And I have a few pictures later. So what is point-of-care definition? This is near patient testing or bedside testing at the time of care. Results are available immediately to improve speed and quality of management decisions. POC testing options are expanding rapidly in all areas of medicine. And using lab tests, handheld instruments, and of course, portable ultrasounds, that's where we are talking today. So think about heart rate, blood pressure, blood sugar, ECG, blood oxygen, sleep monitoring. All of that is point of care, and that's truly the future. So think about it having all on your actually iWatch. Let me just 1 second, please. There's a big noise in the background. Hang on 1 second. I have to get rid of that. I'm so sorry. So sorry. Just a moment. Sorry, I'm back. So sorry, I have to switch this off. So, okay, so that's really the future. You have it all on one device. And now we come to our ultrasound, because even here we have one device, we can do it all. But let's talk about the general principles of point-of-care ultrasound. It's for a well-defined purpose. It's question-driven. It's quick. Findings are easy to recognize. They are easily learned, and they are performed at bedside or in clinic. And my favorite example here is in emergency medicine, and it's the EFAST trauma protocol. So you can see here with a few positions performed in 1 or 2 minutes, the emergency doctor can say if it's blood in the abdomen, if it's a pericardial tamponade, or if it's a pneumothorax, just in a yes/no fashion. And why is that important? Because it's a similar presentation, but different treatments ensue. So coming back to POCUS, this has been a remarkable evolution in the era of handheld devices. So when I started sort of with all of that POCUS in 2014, it was shown that medical students outperformed cardiologists and internists exams. After a short training period on these first generation handheld pocket ultrasounds. Then in 2018, we and others showed that non-radiologists, meaning us, hematologists, physical therapists, and nurses, can easily recognize landmarks and effusions in hemophilic joints with pocket ultrasound after minimal training. And then just more recently, it was shown that untrained non-medical personnel can be guided to perform rapid trauma ultrasound by video in the field. And then finally, just very recently, we have gone to patient self-imaging in real time, very easy with teleguided feature on mobile apps. So this just shows you how rapidly this field is advancing. We are sort of almost, I feel, catching up. Important, though, is to remain within your scope and to always follow this point of care principles. You only look to answer the question. Your ultrasound exam does not replace a full imaging study that's interpreted by a radiologist or, for instance, by a cardiologist to do a full echo. Consider the use of POCUS as an additional tool to glean bedside information. So how does ultrasound generate images? Well, that's pretty simple. Echoes are reflected by tissue structures to create an image. And this is here my knee. I put it up because it has minimal fluid in it, really tiny, milliliter or two, just normal. But the ultrasound picks it up almost in an anatomic depiction of this cartoon here with the femoral condyle lined by cartilage with an interface sign separating the cartilage from the equally dark fluid. You see here a little strip of the suprapatellar bursa, the tendon, patella tendon going into the kneecap. That's the kneecap. So after you have done this 1 or 2 or 3 or 4 or 5 times, you have no problems recognizing these landmarks and making point of care decisions. So how do we use it in hemophilia? Mostly for acute etiology of joint and muscle pains. And here you ask the simple question, is it an effusion? Yes, no. Is it a joint or muscle bleed? Yes, no. Is there hypervascularity, vascular remodeling? We saw the power Doppler signal. Yes, no. And if you get more advanced, not at the beginning, but later, you can ask yourself things like, is there tendon sprain? Yes, no. And here the physical therapists come really in very, very valuably to guide us. Then we have guidance for intra-articular needle placement, needle placement for aspirations and injections, such as corticosteroids. And then we can use it in long-term follow-up of joint findings, although that's less defined and probably less validated and known to help at this point. I think mostly the focus is on acute diagnosis. So acute pain. Subacute and chronic joint pains, symptoms and findings are non-specific. I took this cartoon here from the internet. You can see that all these conditions, arthritic conditions, present to some extent with swelling, redness, loss of range of motion, pain, warmth, and they truly do not discriminate between the underlying etiologies, definitely not telling you if there is bleeding or not reliably. So the clinical exam and patient perception have deemed unreliable and non-specific in several studies now. And so what are imaging modalities to show that there is blood in the joint? Because it matters in terms of treatment or adjustment of prophylaxis, as we will see later. Well, there is the X-ray. It's not sensitive to soft tissue changes, fluid, or bleeding. And I guarantee you, in my emergency room, and I'm sure in yours as well, as soon as a patient shows up, they get an X-ray, and it's completely useless. Then we have CT, that's with contrast and radiation, so shouldn't be done all the time. And then we have the MRI, which is long, inconvenient, costly. And what some of you might not know, but it's now come out, that it's difficult to distinguish blood versus non-bloody effusions with MRI in the joint if no contrast is given. So here now we come to musculoskeletal ultrasound, MUSCAS, and power Doppler and see what it can offer. So what does joint bleed detection look like? So here we have the lateral recess. Here's the ultrasound probe on that lateral knee recess. And you can see that fluid is compressible, synovium is not. So this would be the femur, that's the kneecap, that's retinaculum. And here you see this compressible fluid with some soft tissue swinging in and out of plane. But if this is not an effusion, then it is not compressible. Synovium can look very similar to an effusion. It's this hypoechoic kind of structure, but it's not compressible. You see, this is not compressible, and you can be measuring that directly, as Dr. Goga has alluded to with the CHADE protocol, and it's sort of 7 millimeters, clearly abnormal, up to 1 millimeter is normal. Or you can be going, you can score it. There are several proposed algorithms, but none of them extensively validated. So then how to distinguish? Now you know you have an effusion in the joint. So how do I know if it's bloody or if it's just serous? So let's stick in that lateral recess. You can see here that's a simple effusion. It's really anechoic, blackish, and that would be just serous. And then in the case of bleeding, you have an acute complex effusion. It's hypoechoic with all these speckles, and sometimes so the speckles can be dispersed. They are floating around. So we call it echogenic, and with all these reflectors, and that would be bloody. So what about power Doppler? It can tell you the extent of abnormal intra-articular vascularity, indicating inflammation and vascular remodeling. And I personally find it useful inflammation because it tells me how quote unquote inflamed or vascular the joint is. And so this is one of my patients 2 weeks after ankle bleeding in the subtalar joint space here. And you see this vast power Doppler signal. This is his baseline. Then he had the bleed, and this is 2 weeks later. So perhaps he is still at increased risk for rebleeding. We have no proof of that, but these remodeling vessels that are perhaps leaky with that vascular signal are worrisome. So the physical therapist and I go over that information, and then that really helps the physical therapist to make plans. What to do when MASCAS is not available? Granted, with the new handheld probe, all of it is much easier, but if it's not available, there might be an algorithm to follow here. So several symptom-based algorithms have been developed in the past to assist with self-diagnosis in hemarthrosis and to help distinguish arthropathic pain from painful hemarthrosis. These algorithms are mostly not validated objectively by imaging studies, but they exist. And so we have set out to validate one of those in 2022. And so here we have followed 79 painful episodes with musculoskeletal ultrasound to determine hemarthrosis. And then prior to the ultrasound, the patient got a questionnaire with 20 questions. 10 of those were associated with hemarthrosis, and 10 of those were associated with arthritic pain. And then the questions were scrambled. Patient didn't know. This questionnaire had been developed by the Canadian Haemophilia Society with an experienced international panel of hemophilia patients, but again, at the time was not validated. And we thought we'd just see with musculoskeletal ultrasounds, what do people tell us? And then what's really objectively seen. And with that, we were able to tabulate the 20 symptoms by increasing odds for hemarthrosis. So you can see here the likelihood of arthritic pain based on to which questions they said yes. And on the other hand, the sinking of likelihood of hemarthrosis pain with the answering of questions. And so that has been compiled into an algorithm for likely or non-likely hemarthrosis based on these on this algorithm, these questions. So it's one way, but I think if one has an ultrasound available, is still the better way. So now what about MASCAS guided needle placement for injections and aspirations? These are the preferred positions for the ankle here, medial, for the knee, lateral into the suprapatellar bursa, and then the elbow, I like posterior into the olecranon fossa. Why is that important? And in our course, we teach that because it's been shown that it helps to aspirate and it also helps to inject steroids. So for painful hemophilic joints, here is the efficacy of intra-articular MASCAS-guided steroid injections. You can see here the extent of pain relief that was before the injection and then after the injection on a VAS scale of 0 to 10. And then here is the duration of pain relief individualized for patients, but you can see that most patients had sort of sometime between 4 and 8, even up to 12 weeks of pain relief. And that's not insignificant because you can repeat these every few months. And patients will tell you that's not just the pain relief, they now can also do things that they couldn't do before. And come back to that reduction of vascularity. Steroids are an excellent means of reducing vascularity. I'm not certain that that's what drives the pain or is associated with pain relief, but you can clearly see that here in the knee, in the infrapatellar fat pad, and here in the olecranon fossa, after the injection, a week after or so, that vascularity is gone, and maybe that might also help with a silent bleeding. So joint aspiration in hemophilia, by that same token, provides a chance once you are in with the needle. You might as well aspirate and then perhaps, if you want, give a little bit of steroid back, but it provides a chance to remove iron. Clearly, it does not replace acute treatment with clotting factor to stop the bleed, but at least you get the iron out, and it's safe. It accelerates and improves recovery and rehabilitation. It's beneficial for pain relief, and an Australian group went so far to go to joint lavage with intra-articular steroids after hemarthrosis, and shows that it really preserves children's joints. And this is a listing of the study to date in hemophilia who have shown benefits of joint aspiration. So now a little bit on long-term follow-up. How do we do that? Most of us know the clinical hemophilia joint health score from 0 to 20. So this is a clinical examination that sometimes it can be lengthy. I have heard up to an hour or so. There's some abbreviated protocol possible as well, but it's a clinical score. With a clinical score, we still don't know what drives that clinical progression. To that point, years ago, like 30 or so 40 years ago, Dr. Pedersen created the Pedersen score, and that's an X-ray score with visible changes in the domains of cartilage and bone, which now in the modern era of hemophilia treatments really too late. Once you see bony changes, you want to catch them earlier. So they have sort of become obsolete. We don't do them anymore. But based on this being too late to the game, an MRI score was developed by the International Prophylaxis Study Group, and that also has a score from 0 to 17, but it can show soft tissue changes for sure. So those usually precede bone and cartilage, but it's really too cumbersome and too expensive, especially little children. You cannot put them every 6 months for each joint into an MRI scanner. It's not feasible. So therefore, we come back again to musculoskeletal ultrasound. One can use it for longitudinal evaluation. And here we use direct measurements. They are quantitative with the CHADE protocol. We have a second edition now. The CHADE protocol is incorporated in clinical trials. It's fully validated by OMERAC guidelines. And you can see here how one can measure osteochondral alterations, cartilage thickness, soft tissue expansion. We already had that photo of synovial hypertrophy, and then finally vascularity and inflammation. Now, a few words about CHADE. So these are all the publications in terms of validation to capture these fluctuating tissue changes. Direct measurements are considered preferable to scoring algorithms based on trends in rheumatology. You can send them here to the right, because they avoid ceiling effects. They reduce subjectivity and pattern recognition, needing to recognize something on an ultrasound to give it a score. Enable the charting of subtle changes separately for soft tissue swelling, cartilage thickness, osteochondral alterations, so it's not all emulated into a total score. And then additional advantages are that CHADE enables the detection of effusions and bleeds. It enables the detection of inflammation and vascular remodeling with power Doppler, as we already seen. And what are the validation points to be made for OMERAC guidelines? Well, that's for one, correct tissue identification and annotation. What does pathologic synovium look like, for instance, is one. Intra and inter-reader and inter-operator reliability over time. the consistency of readings over time, and then the clinical applicability for specific disease states and patient cohorts. So all of that has been done, and so that makes JADE a really versatile MUSCAS protocol for a wide range of pathologic findings. So it's highly suitable for clinical management and as a study outcome measure. And that just gives you some examples here for synovial thickness and cartilage thickness and how it correlates with hemophilia joint health score and also total arc. So here you see, for instance, the measurements of the synovial thickness in the medial recess, or you see here cartilage thickness measurements in the femoral patellar area, here with cartilage thickness measurements. And again, it correlates really well with these other clinical parameters, and these measurements are consistent. So now we have these new handheld devices, and they really open a new era for rapid bleed detection. I want to go back to acute detection rather than long-term follow-up, because while we use it for long-term follow-ups, really no study has yet shown that using the ultrasound for long-term follow-up provides really a benefit to patient in terms of adjustment of measures or treatments or management plan. And this is really important to internalize, because we can use it, but it's more for study and outcome studies, etc., rather than for clinical application, long-term follow-up. However, short-term diagnosis of bleeding, yes, no, it's invaluable. And so I show that here in a patient at baseline. That's the artery, so don't get confused, but that's long axis, the tip-tail joint space, and that's short axis. And you see here a very tiny, tight joint space. Here it's not even visible. And then with a bleed, you can see the filling of that joint bleed here with this hypoechoic kind of speckled echogenic material. It would compress on compression. And this is sort of on a big, good, expensive ultrasound machine, but then go to one of the cheapest machines right now. It's called Butterfly. You can see that it's a bit fuzzy and maybe not as ideal with one of these wonderful machines, but you can easily detect bleeding, yes, no, and that's maybe all you need. And again, we have shown that any non-radiologist can be trained in a very short period of time and recognize bleeding and joint landmarks. So I want to show you the advance of image quality, though, with handheld devices, and they are very affordable. So this was one of the first ones here. That were the 2014 medical students I showed you who outdid internist exams. So it was still pretty fuzzy, but you could see that there was, you could see the anatomy quite well. But then this is the next generation device where you plug the transducer into the cell phone with a crystal transducer, and you can see it gets a lot crisper. You see this little effusion here again, and you see the interface sign. And then this is what I just showed you. That's that digital chip device, the Butterfly. It actually creates images not via a crystal transducer, but by a digital chip technology that's proprietary. While again, it's a bit fuzzy, you can still see a little bit fluid here in the elbow, just similar to this one, and can still see the little fluid here. As you can see it here, you just have to get a little more used to a fuzzy image. But all in all, that's maybe again all one needs. And then we go to tele-ultrasound, facilitates really non-expert-expert connection. You can see me here in remote image acquisition with a patient at home and a caregiver helping him here to visualize the suprapatellar bursa. And I am seeing this in real time on my computer in the office, not only the ultrasound image, but also how the patient or the caregiver holds the probe. And so I can immediately correct, and we get an image, and that might really be helpful for remote areas where we need to make bleed diagnoses. And moreover, we have shown that in a pilot study of 10 patients, patient could acquire imaging after a short training period accurately with near perfect image quality. Image acquisition was fast. That's our physical therapist here, Peter, working with a patient on image acquisition via telemedicine. And so even the older patients, it's not a young guy, thought that it was easy to navigate mobile technology and acquire images. So that is something to really think for in the future. Introduction of MuSCAS, as you can see, just not has transformed, but is really transforming hemophilia management. In an international survey from the International Prophylaxis Study Group, 91 of 103 hemophilia treatment centers, that's 88%, reported that they use MuSCAS, and it's most useful to confirm or rule out acute joint bleeding. Again, comes back to what I said before. Long-term joint health follow-up might still be somewhat in the realm of research. And then in a prospective multi-center cohort study, it was found that routine MuSCAS assessment informed about 50% of physical therapy plans with joint-specific measures, much less any kind of hemostatic plans. But again, what we don't know, and I want to point it out, is that this informing plans will really, and making plans according to ultrasound findings, then will really translate into a outcome benefit. So we don't have those studies yet. So just have that in your mind. It's logic it would, it's sort of conducive to thinking it would, but we really don't have entire proof of concept on that aspect. So merging into the mainstream, I would like to show you a couple of pictures of last classes. So this is in Buenos Aires at the World Federation of Hemophilia workshop in 2023 using these handheld devices. Then this is at a twinning workshop in Maputo last year, followed by our workshop in Johannesburg, which I really still think back very fondly. It was a wonderful event, and I hope everyone went back with new skills and is using them in clinic now. And then we just had our a large workshop in Madrid with all international providers to again learn this technique. And while we learn on large machines, we use the small ones for practice. So if you wish to train, are not shy, contact us. We do have a CME accredited class here at UCSD, not only for musculoskeletal ultrasound, we also introduced that now for vascular ultrasound, for deep venous thrombosis imaging, because we are hematologists. That's the other end of the spectrum of diseases we see, and we need to provide a direct diagnosis or follow-up there as well. And contact us, either me or Peter or our course coordinator. And we have also financial assistance programs available if you need to travel or such. So now what are our treatment options of progressive arthropathy? Well, now that we have diagnosed it all, there is really no good algorithm. You have to try to find the cause of the arthropathy. Obviously, it is there because of hemophilia, but there might be many other factors that are equally important and either ameliorating or deteriorating that particular joint state. And you have to manage accordingly in a multidisciplinary fashion. Give you some examples. For instance, you find mechanical joint instability or structural tissue injuries, for instance, a meniscus tear, then you need more imaging studies. Ultrasound won't do it, and you need PT evaluation, and then you have to go down that tangent. However, maybe you have aspirated that joint and you find crystal disease. It could be gout or pseudogout, and especially in the adult world, I would just encourage you to really make a diagnosis, because not all bleeding, or not all, as we saw, not all swelling or joint pain is always related to bleeding. Adults are adults, and they develop gout, they develop pseudogout, they develop other things that one needs to be on top of because they are treated differently. And so aspiration really helps there in sending out the fluid. There can be other arthritic conditions or infections present, and then you have to treat accordingly. Patients can have synovitis. So what would one do that here would be synovectomy. That can be done surgically, although it's not the preferred method. Better would be radiosynovectomy or chemical synovectomy, or embolization. It's microembolization through arterial access. And then, of course, if the patient continues to bleed and you feel that patient is on suboptimal hemophilia prophylaxis or has developed an inhibitor, one has to optimize prophylaxis. But one doesn't exclude the other. This is just sort of a snapshot on what you have to think about if you see a patient with an arthropathic joint in front of you. It's not all bleeding. There are lots of other things to think about, and pull in your multidisciplinary team to help you. So in summary, joint bleeds and progressive arthropathy are unavoidable despite prophylaxis. POC imaging with MUSCAS is essential to determine bleed status, especially in the face of novel prophylactic treatment options. Handheld ultrasound technology is revolutionizing access and care to facilitate rapid and informed management decisions. And then long-term follow-up and screening, applying ultrasound protocols is feasible, but needs study to determine improvement in outcomes. So with that, I thank you very much and take questions.
Prof. Annette, thank you so much for this excellent presentation, really honing it into the 4 points that we need to look at. Whilst people are just getting their thoughts together, we have come some way in terms of prophylaxis. It is rather slow. And what we decided was to focus on pediatrics because that was where everything started.
Mm-hmm.
There are some challenges in terms of acceptance and implementation of prophylaxis in the adult population. And unfortunately, we do have resource constraints. So at this point, much of it is blamed on resources, but I think also it is a significant mindset change that needs to be made. Would you mind just commenting on prophylaxis in the adult population and some of the approaches that we might use specifically in adults?
Yeah, thank you for that question. I understand we would call it tertiary prophylaxis or such if one puts an adult patient on prophylaxis who maybe, if I understand you correctly, hasn't had any kind of prophylaxis before. So let's say there are 2 different scenarios I could imagine. Someone is a child, is on prophylaxis, has had very little joint bleeds with that, and then goes into adulthood. Let me ask you, would you take him off prophylaxis at that point? So that's one scenario. The other is patient has never been on prophylaxis, but now we have all these options for prophylaxis. And do we put that adult patient at the age of 40 or 50 on prophylaxis? So two little different things. Could you tell me what you think is most prevalent in South Africa or what you are dealing with?
So I think, the transition period is always one that brings a lot of anxiety because there is, as I say, significant constraints. And often the patients who have been on prophylaxis as children, it might be curtailed. It isn't always easy to access. And then there's the second scenario that you've outlined now, which is a patient who is, let's call him tertiary prophylaxis naive. The question really is to try and show the benefit in those 2 population groups of continuing it and how to get people on board.
Yeah, so if you have that child that goes off prophylaxis, that's a shame because they will start joint bleeding. So everything you have reached throughout a young, childhood and young adulthood in terms of preserving joints will go away once that person in their 20s starts joint bleeding. So you haven't helped the system if you talk about cost effectiveness and productivity, because you start to cripple someone who you did the right thing in terms of preventing joint bleeds and making him a normal member of society. So in my view, my view counts obviously, but that's a shame. That's really sad. The other way around, to start someone who has never had prophylaxis, they already have bad joints. Now, what can ask yourself, what does prophylaxis do? Well, it will stop the bleeding. It's truly unclear to what extent joints can deteriorate even worse than they already are. There is a study by Dr. Manko Johnson here. She is in the US in Colorado to actually demonstrate. So I don't know if you know, but she has done these seminal trials in 2007 to show that prophylaxis matters, published in the New England Journal of Medicine. So it took toddlers. She put one group on prophylaxis and the other one on episodic. And after 3 years, it was very clear, obviously, that the episodic treatments led to joint destruction and the other kids had near normal joints. But she followed that cohort, so that was clear. But then she followed that cohort and 20 years later took a look at what happened to those children who didn't have prophylaxis when they were little, got prophylaxis later after 3 or 4 years after the study were done. But in those first few years, they just were chasing their bleeds. And it was clear that although they went on prophylaxis later, their joints still suffered from severe damage, much more than the group who had early prophylaxis. So I think that brings back the point. It's really important to maintain prophylaxis throughout childhood. And then she did another study where she looked at adults and that point, what happens if adults are not on prophylaxis? And yes, their joints deteriorate. They do, but it's not as impressive as if we go back to the children. So if one is in a resource-constrained environment, I understand that it is difficult to put adults on prophylaxis, although it would be very helpful to them because they still bleed and then they don't have to deal with joint bleeds and deteriorating joints. I know it's long-winded, it's not an easy answer, but if you have to make a choice, I would think it's continuing the children. And I see Dr. Malangu there. Johnny raises his hand. Maybe he can contribute. Help me.
Thank you, Annette. Through you, Chair. Thanks again for this very comprehensive overview of the musculoskeletal aspects of hemophilia. Yeah, I mean, I couldn't agree with you more that if one has got an option, rather put pediatric on prophylaxis. Although, in fact, I must admit it varies according to centers. In our setting, once you are on prophylaxis, we tend not to take you off prophylaxis. We will make all kinds of plans to make sure that you remain on prophylaxis. But the real reason I put up my hand is along the lines of the natural progression of hemophilic arthropathy. You mentioned that breakthrough bleeds, and you've shown us the evidence that breakthrough bleeds do contribute to hemophilic arthropathy. What is unclear to me is if everyone was on prophylaxis, are we likely to get rid of hemophilic arthropathy completely? In other words, can we eliminate hemophilic arthropathy with prophylaxis or not?
I don't think so. So this was the at the very beginning. I'm not sure if you were on already. There's a new meta-analysis summarizing sort of 48 studies of interventional and 10 observational studies in regards to all comers on factor VIII prophylaxis. And they do have breakthrough bleeds, and a minority of patients has 0 bleeds. So they do happen, even on the best of all prophylaxis treatments, even on Hemlibra, as we all know, they happen. And then it depends on, of course, how many and how prone an individual is to sort of put them away or to develop arthropathy. But I don't think we can entirely eliminate it. It will always be a problem, but maybe not as much of a problem.
Thank you. Yeah, I mean, that's my impression as well, is that the natural history of intra-articular bleeds lends itself to progression despite prophylaxis. And therefore, one just needs to face the reality that, once you bleed into the joints, it sets a process that is very difficult to hold completely. The other question I wanted to ask, when you've got your skill set right and you are an expert in ultrasonography like you are, it's unclear to me if someone has already got evolved hemophilic arthropathy. What is the utility? To what extent is it helpful to do ultrasonography in that setting?
To rule out a bleed, like that's how it started all in my practice, because I have very arthropathic aging patients. And so they come with acute pains or with joint pains, and they say, oh, my joint hurts, and I think I have a bleed. And some of them don't even want to infuse factor at the time because it's hard for them. They have crippled joints, crippled elbows. It's hard for them to self-access, actually. And maybe, or they did, and the pain didn't go away. So then it's really helpful to have that distinction. Is the pain associated with bleeding, or is it not? Because if it's bleeding, we go down one set of algorithms. But if it's not bleeding, then what is it due to, and what are we missing? Or if there's not blood in the joint, but a serous effusion, it might be any aspirate, it might be gout or pseudo gout, and entirely unrelated. So 10 more factor infusions won't help that issue, right? So this is how it all started, and why it might be so important in a especially resource limited environment to know, is it a bleed or not? And if not, then that's great. Don't have to do any factor or anything, but what's next? Really simple in that sense.
Thank you. My last question relates to exactly that. Are you able, once you have the expertise of ultrasonography, able to differentiate between old blood and fresh blood?
Yeah, that's a little more difficult question. So old blood will be usually clotted, I guess. And in that sense, it's not compressible anymore. And as soon as something is not compressible anymore in the joint space, but you think it's a little squishy, it could be any tissue. It could be synovium. It could be old clotted blood. I don't think the ultrasound will be helpful anymore, but you can say clearly, probably it's not an acute bleed that just happened, because that would be swirling red blood cells. It would be compressible.
Thank you. Thanks, Annette, again for this very comprehensive overview.
No, thank you for the questions and helping me out with answers too. I think I have some in the chat. Should I read them? Someone asked, in terms of ultrasound guided joint aspiration, is it done under factor cover or not? Yes, it is done under factor cover. But what I have, yeah. So what I usually do is I try to aspirate the joint first and then give the factor, because if I give the factor first, it starts to coagulate sometimes really fast, and then all you have is a hematoma in the joint and cannot easily aspirate it anymore. So if a patient calls in and says, I think I have a joint bleed, can you please check? Then I said, okay, if you can, if you don't live 3 hours away, if you can, hold off the infusion right now, come to clinic right away. We determine it's a bleed, we aspirate, then we give you the factor. Bring your factor, usually. And then we inject it in clinic. And then I send off fluid. So if it's clear that it's not, even if it's bloodily tinged, I always send off the fluid for crystals and for white cells to see, again, gout, pseudo-gout, or maybe infection. And I also send for a gram stain. Sort of, I do the usual, good internal medicine practice protocol. Someone said, one of our registrars that is also on this call has become our resident POCUS expert at the Haemophilia Clinic. She was using a more advanced platform that has now been supplemented with a plug-and-play transducer. No power Doppler capability with the latter. That's fantastic. I have to say, I don't know what a plug-and-play transducer is. You have to let me know. Is that something new? Or what does it do?
Annette, no, it's not something new. It's just the one that you just plug into your handheld and use it.
Oh, I
The
see.
portable transducer.
And how is that going? Hi, by the way. How is that
Yeah,
going?
it goes. Certainly, she's done a lot of work in patients, adult patients with hemophilia and evaluating those joints. We want to compare it also, like you've done, to the health joint score and to both clinical and radiological evaluation. And we're planning a larger, almost like national project, and that's why we got these. It's the Philips handheld transducer that we got. Yes, unfortunately, Lumify, yes.
Okay,
And I
great.
think the resolution is fine. In terms of if you compare it to the blood butterfly, and it's easier to use, it's not so bulky. And then what we now need to do is actually to train the trainer at our hospital so that we can get the pediatricians in their clinic and also some of the other healthcare professionals that are involved in the clinic also trained up. Yes, so that's where we're currently at. Thanks again. It's really wonderful, and I would like the audience to know that there's also lots of support. So after you've been trained, you can dial into meetings. So it's about twice a month that Annette and her team does meetings, and you can present challenging cases, and they do also offer support. So there's always some support if you need it. Thank you so much for that too. Thanks.
Oh, yes, awesome. Thank you, Johan, for mentioning that. Yes, so every 2 weeks, actually, Peter and a couple of other physiotherapists in the United States carry out a it's grand round. We call it Muscas Grand Rounds. It's at 7 a.m. our time, so that would be 4 p.m. your time or such. And everyone brings cases to the table. So you share your desktop and you discuss cases, and everyone can bring their uncertainties, and yeah, it's a lot of learning there, and these are good meetings. Yes, if you need to, please let me know. So, and then we put you on the invite, on the Zoom invite link, and then you can just click that link and join. Even if you have nothing to present, you can just watch.
Annette, can I ask you maybe a slightly different question? You've done gene therapy, and you have obviously been using replacement therapy for many years. What is your impression of gene therapy as the ultimate prophylaxis for hemophilia patients? Say we had a magic wand where everyone could have gene therapy. Do you think then would not worry about prophylaxis at all, and then no need to learn very useful skills such as ultrasonography?
I think you will always need ultrasonography because there is always that joint bleed that might happen. But to your point, Johnny, and I think I mentioned this quite a bit, you have actually re-educated me in terms of the usefulness of gene therapy, because here, and by the way, I mentioned this, we have on Wednesday our first commercial gene therapy with Hemgenix factor 9 deficiency at UC San Diego. The point being, what worries me, not so much for factor 9, but for factor 8 gene therapy, is the extensive use of steroids. And the unpredictability of where the patient will land in terms of will the patient be normal or maybe just end up at 3 or 5%. And that has led to quite some discussions in the United States. However, talking to you, I've began to backpedal, because you are right. At the end of the day, even if a patient ends up at 3 or 5% or 10%, which we would not think as optimal in the States, it's very meaningful in resource-restricted countries, because you don't need to use clotting factor. Most patients are fine. And so I would bounce that back to you. What do you think about this prolonged steroid use with factor VIII gene therapy? What are your thoughts? This is my sort of block or backdraw, but what do you think?
Annette, I just came back from ASGCT, and it is actually very encouraging and enlightening to see that the use of steroids in the context of gene therapy is probably a reflection of the early evolution of gene therapy. You know, if one were to cast your sight, ahead, there are many more therapies, including gene editing, including lentivirus, etc., that at least the data that was presented at ASGCT suggests that they may not need to use steroids at all. So I'm hoping that in fact we're just going through a learning curve. This is not going to be a permanent feature in our quest to cure hemophilia in our patients.
Yes, and then if we go to these integrating technologies or editing, then that could be applied in childhood. And I think this is where, coming back to our original question with prophylaxis, where it's most helpful, most useful, and most needed is to preserve these joints through childhood, and then on forward, it won't be such a problem, clearly. Yeah, so for the moment now, the discussions are big because it is approved here and we have patients wanting it and they're getting it if they qualify after long discussions with the patients, the pros and the cons. No doubt took me about 1 year in our hospital to get it all running, away from clinical trial activity to really now commercially. Someone has to put visually $3.5 million on the table for that treatment. And that took about a year to sort out. So you can imagine that is a leap of faith from the hospital side, and then hopefully getting reimbursed. But I think it's in place now, and we will see. And what one patient told me, well, if it doesn't work, what's the worst? I'm going back to prophylaxis. I said, yeah, that's probably the worst. So it is a work in process.
Johan, do you want to perhaps speak about what the possible plans are from a MASAC perspective in terms of making the access more available? And I think I'm excited now with the possibility of us being able to use less costly probes, although in rand amounts, it still is quite a lot. But I think there's also, and perhaps Prof, you can comment in terms of, for patients to actually see what's happening in their joints, and then for them to understand where prophylaxis fits in, especially from a pediatric perspective, in terms of improving compliance. And the same could be said of the adult population. It's not easy for people to poke themselves 3 times a week. But if you can actually see what's happening in your joint, I think it actually improves what your outcomes are from a patient buy-in perspective.
If I may, Jasmine, I think that Annette has a lot of experience in terms of that. And especially if you think about teenage boys, they're very interested in what happens in the joint, and they're very interested in gadgets. And I think there are some patients, certainly not everyone, because it is still more expensive, but the transducers are, I think, becoming cheaper all along. And I think there are novel type of things that are probably going to reach the market, which patients can use together with their mobile as a handheld to do imaging on their joints, and I think that this is certainly an area where I think that we should actually engage the patients. The patients are very interested and they're very engaging if they can see what happens in their joints and can visualize that. And so I think that's what we should be doing. And I think that going forward, I think for the major centers, I think every major center in South Africa already has capability of doing even if it's limited, ultrasonography. And I think that if you don't have, there's certainly in the institute where you're working, equipment available that can be shared, even if it's with the rheumatologists, or there's certainly equipment available in every large hospital. And I think that we should make an effort to engage with whoever it belongs to so that we can have access to that. And I think that the first focus, I would think, is that we train people to be able to do this and get the basic skills done. I think the equipment shouldn't be something that holds us back. That should be the least of the concerns, but that we should be able to actually treat people up to be able to use it appropriately. Yes, my 5 cents worth. Thanks.
No, absolutely. There are no, unfortunately, hard to believe, but there are no real studies. You brought it up, Yasmin and Johan, regarding the adherence and buy-in for certain concepts with patients if they see the ultrasound picture. And that is absolutely true. We experience it every day in clinical practice, I think, but it's not been officially studied. So this would be a great study to do, how visualization of findings on ultrasound really reflects or translates into patient adherence and buy-in. Something to think about. Maybe as a collaboration, I'm all for it.
So we look forward to working together in that space. And I think also just in terms of trying to engage with more training workshops in the future, because I think, one does not have to have the detailed, one needs to be able to decide initially, is this a bleed or is this something that is a chronic degeneration of the joint? So if we can start at that point, we can then justify our factor usage to a better extent, and then work on the combined study in terms of adherence. And I would also like to include a health provider aspect to that, because I think also for health providers who are holding back, actually seeing what's happening may influence what their prescribing practice would be. I'm not sure if there's any further comments from Prof. Mihlangu.
Yasmin, no, thank you. I don't have any further comments. Perhaps to thank Annette for this very enlightening overview.
No,
Okay,
thank
so-
you all. Thank you for being on for this presentation. It was such a pleasure to talk and be engaged with you all and discuss. This really wonderful. Thank you for this opportunity.
Okay, so Prof. Annette, thank you from the deep dive team and from the hematology community in South Africa. And also thanks to Roche for facilitating this session as well. There should be the survey that is coming through on the chat, and remember to add your details in. Just a heads up about next week's topic. What it stands as is platelets as a blood product. So we look forward to next week's topic as well. Thanks once again, and enjoy the rest of your day, Prof. Annette.
Thank you. Bye. Happy evening.
Thanks, everyone.
Thank you.